Hello, I'm Bernard Gersh for European Heart Journal Today. With me is my boss, the editor, Tom Lüscher of the European Heart Journal. But here to talk about an area that's been very controversial, and that is the guidelines for the perioperative management of patients with undergoing non-cardiac surgery, and in particular the controversy surrounding beta blockers. And Tom, I think this is a very opportune time because new guidelines have come out, and there's been a lot of correspondence back and forth between the ACC, AHA, and the ESC, and I think a consensus. But can you give me some of the background, or give us some of the background to the controversy that I think is now resolved, but there has been a controversy?
Well, there have been quite a few trials, mainly 6 trials, some of them big, like the POISE trial, and some rather small, like the 5 others, that dealt with the question whether during an operation, a high-risk operation, if we were to reduce the oxygen consumption of the heart, whether we could reduce myocardial infarctions, which is a feared complication.
And I think it's fair to say that the premise is a valid one, and that is in the perioperative period, there's increased sympathetic overactivity, increased tachycardia, increased platelet aggregation, and increased oxygen demands,
and so on, yes. So this made a lot of sense. Now, unfortunately, not all these trials had the same result. And in 2009, the ESC published their guideline on this issue with Don Poldermans as the main editor or writer of these guidelines. And these were into effect until in 2011, there was a concern about...
So the guidelines initially, based upon, I think it was a series of trials, the decreased trials.
The
guideline, the recommendation was to use beta blockers preoperatively and perioperatively.
In high-risk patients to avoid myocardial infarctions. And this was sort of common practice for a while, although, as I said, the results of the trials were not really in line. The decrease trial was rather positive with oprolol, while the POISE trial, which was quite big, 8,300 patients, was negative in terms of mortality and stroke, positive in terms of myocardial infarction. So both trials found that infarction was less, but on the mortality issue, which is of course very important for the patient, there were not consistent results. But overall, the consensus at that time was that it should be given, and it was said that the POISE trial used a rather high dose of metoprolol and immediately before surgery, while in the decreased trial it was given a bit before surgery, and possibly this was the difference, that they had more hypotension in POISE and therefore more strokes and death.
In retrospect, I've gone back and looked at the original trials. There was a huge difference based on, in favor of beta blockers, a relatively small group of patients. And I think
in the decreased trial, yes.
In the decreased trial. But in POISE, I mean, it was a legitimate concern, I suppose, that it was quite a high dose of beta blockers.
Yes.
It started relatively soon preoperatively.
In the first 2 days, and up to 200 milligrams of metoprolol succinate.
That's a lot.
That's a lot, and therefore they saw this. And so anyway, this was the consensus. And then these guidelines were into effect until, as I said, the main author of the decreased trial and the guidelines was dismissed from Erasmus University because of a concern with the performance of his scientific projects. And of course, we all were then concerned. We actually, as an editor who has published work under his name, I called the investigative committee, but they couldn't tell us at that time what was valid and what was not. Then in July 2013, an English group, Cole and Francis, published a meta-analysis in Heart, whereby they showed that if one would take out the decrease studies, that then there was a clear signal for an overmortality, more strokes, and less infarctions.
And if I remember rightly, I know that meta-analysis, it was a good one. When they published the POISE trial, they also, I think, published at the same time a meta-analysis with and without the decreased trials, showing the same thing, that if you took them out, there was a trend
the data
towards
are
harm.
quite clear. I mean, it is not consistent. Now, this occurs often in medicine, and we should be careful in moving right away to a fraud accusation. And therefore, I was watching this carefully. And but then in July, when this came out, the ESC and in fact also the European Heart Journal posted a warning on their platform and asked physicians to use beta blockers with care and only on an individual basis. And at the same time, the ESC board asked for a committee under the leadership of Sten Christensen and Johanni Knuti to provide a new guideline. And this, as this was such a touchy issue, we actually worked very closely together with our American colleagues.
There's one point I'd like to make, and I mean, I made that in a talk I gave today. Guidelines are guidelines. Yes. They are not legal statutes. No. Every time we publish and finish a guideline, yes, it's probably going to have periods of obsolescence because of new developments.
Yes, and in some areas there is not very solid evidence, and this was indeed the case, and particularly if there are two trials that contradict each other, at least partially, it's getting very difficult.
So the final recommendations based on the September publication, yes, September?
We are now much more careful, and we say that first of all, the most important message is if patients are on a beta blocker, we wouldn't stop it for an operation. And this is a very important statement because many patients take these drugs. The second is that the beta blockers should be used with great care and only considered in high-risk patients and given early before the operation, not in the day before the operation, but earlier. And this has been downgraded to 2B. And therefore,
when earlier, so starting a week or 2 weeks before.
Yes, but it's 2B now, and so it's really close to not recommended. So I think for the practicing physician, if the patient is on a beta blocker, leave him on. If he's not, then think it over twice before you use one. And if you do so because you're concerned about the ischemia that may occur during the operation, try to start it on a moderate dose and maybe a week or two before.
Tom, I do that in my own practice, and one question, I don't know that we have the evidence, but it has never been my intention to beta block a patient completely. Yes. In other words, I think that in the perioperative period, you want to be able to have a relative tachycardia. Right. So what I've done when I've started it, I like to make sure they can get a pulse rate up in the 100, 110 range.
Right. I mean, this is a very good point because otherwise you don't have the reflexes to cope with the situation that is very volume dependent during an intervention or an operation.
Thank you very much for clarifying this, Tom.
Thank you, Bernard.